Okay, we're just about ready to convene. Hi, everybody. I'm Lori Holleran Steiker. I'm an associate professor at the University of Texas School of Social Work. I'm associated with a number of the agencies in the room, and you are my dear friends. I'm a person in long-term recovery, and for me that means that I haven't had to have any substances since August of 1987, and it allows me to be, thank you, and I get the opportunity to be a mother and a wife and a friend and a member of this magnificent community, and I am so grateful to be here. It is my honor, privilege, and joy to be up here on stage with Dr. John Kelly. Dr. Kelly is professor of psychiatry at Harvard Medical School, associate director of the Mass General Hospital, Harvard Center for Addictions Medicine, the program director of the MGH Addiction Recovery Management Services, and has just been given a special professorship through Harvard for his work in the addictions. Can we welcome him with an applause? We're so lucky to have him. And when we were designing this conference, we were trying to figure out what we would have Dr. Kelly talk about. He has done research in so many areas that he could talk about 12-step recovery, he could talk about RCOs, he could talk about spirituality and recovery, relapse prevention, just about roads to recovery. And so we couldn't make up our minds. So I sort of jokingly said, can I be your Oprah and just ask a bunch of questions and have you respond to them? And so Dr. Kelly was game. This is a new format for us. So we're hoping that it'll be useful to you to cover a lot of ground. And then we're going to open it up at about 11:45 for questions if you have any. So I can continue my Oprah deal and run around with the mic and get your questions. So, yeah, this is a fantasy of mine, I have to admit. So, I guess that's become infinitely clear that I'm a frustrated entertainer. But that aside, so let's get started. I want to thank Tom Hill for his introduction and everybody that spoke, Cynthia, Jason. The information about what we're doing in this state is mind-blowing, and it is inspiring, and I think that we really have some momentum here. As Tom said, as a community, we celebrate your revolutionary research, which combats stigma of addiction through science. And without that science, we are speaking from experience only, and now we get to speak with the power of experience and research. You've made it clear in your work that language is powerful in the recovery movement. Michael Botticelli, our drug czar, notes the injurious negative words used for addicts: clean versus dirty, patient versus person, abuser versus person in long-term recovery. So we want to start by talking about the impact of language in the field and what your findings have been in terms of the research around language.
Great, thank you, Laurie, and it's an honor to be here. Thank you for inviting me. It really is an honor and a privilege to be here with you all. When Laurie invited me, we were brainstorming, as she said, about I will get to this question. I'm not avoiding the issue, but we were brainstorming, and she said, well, why don't we try this format? You see, I'm so used to having my PowerPoint slides to alleviate my anxiety and guide myself through what I'm going to say. And she said, well, what about this? So I was like, oh, okay, we'll give it a shot. And so without my PowerPoint, I'm always a little bit more anxious, but I'm very happy to do this. I have to rely on my higher PowerPoint, I think, this morning. It's nice to be able to just, talk more like a conversation, I think, around all of this. Hopefully you can hear me. I'll try to remember to speak loudly so you can hear me clearly. But coming back to this very important topic of language, I really didn't think much about language at all until really probably the last 10 years and how important it is in terms of, especially with very stigmatized conditions like addiction. It's even more important. And this came to light to me, really hit me between the eyes when I started doing research in how language and certain terms in the field actually affects our attitudes. Now, going back to when I was in graduate school and I was doing my research and my dissertation, I published my first research paper in 2000, for example. When I published that paper, the language that I used in that paper, looking back, when I was reviewing that paper now, I described individuals as substance abusers. Now, at the time, I didn't think anything of that. Now, I can tell you quickly that the term substance abuser, describing someone as a drug abuser, actually seems to induce implicit negative cognitive biases against people with addiction problems. Interesting. Now, I can tell you at the time when I wrote that paper, I was just following the lead of my mentors, and that's what people use. They describe people as drug abusers, alcohol abusers, substance abusers, and I did the same. I can tell you, my heart was like, I want to make a difference in the world of addiction recovery. I wasn't thinking this is stigmatizing, this could potentially be a negative. I've come to learn that actually those terms in particular seem to produce different effects in folks. So our language, of course, it both reflects and influences our approach. And in the modern era, we have kind of really led by the National Institute of Drug Abuse and Nora Volkov have really started to describe much more forcefully the idea that addiction is a disease of the brain. And it's a chronically relapsing brain disease. Now, the idea behind that, of course, now it is true that it is disease of the brain when you look at the definition of disease. Yes, it does fit with the definition of disease. Now, what seems to be very interesting and kind of ironic is when we describe it as a chronically relapsing brain disease, they've done studies. Actually, when people are viewed as having a chronically relapsing brain disease, people think they cannot get better. So we have to be careful, and I know Bill White, who was mentioned earlier, Tom Hill mentioned Bill, who has really been an architect, the architect, one would argue, of this movement, in terms of a lot of the conceptual domains that we talk about. But he says, that if we talk about addiction as a disease of the brain, that we should also remember to talk about that it is treatable, and that most people recover from addiction. About 60% of people achieve full sustained remission and recovery. It's a good prognosis disorder. Let's not forget to mention that, right? And this is part of the, basis for the recovery movement, right, is to communicate that. Now, coming back to the specific language that how we describe the disease of addiction and people who suffer from it, I began to, in the last 10 years, I began to kind of get worried about this term abuse and abuser in particular. I thought this kind of seems like very prerogative and derogatory to describe someone as an abuser. And then when I started researching it, back in the 1970s actually, the World Health Organization actually said we should not use the term abuse because it will give rise to the term abuser, which has even more stigmatizing connotations like being a child abuser, for example. So they actually advocated against adopting the term abuse. However, of course, here in DSM nomenclature and in our national institutes, we did adopt the term abuse. Now, there was a kind of a cultural aspect to that too, because there was adopted and waged in 1970 the war on drugs. So there is a rhetoric that goes along with the war on drugs. You use, you lose, you're a drug abuser, therefore you are implying that you have volitional control over your choice to use a substance. If you're abusing it, then that implies a kind of willful misconduct. And you can kind of contrast that with the idea of having a disorder, like a substance use disorder, right? So this is what kind of piqued my interest, and I thought, we need to get rid of this term abuse and abuser. And then I wondered what kind of an impact it would have if we exposed people to these different terms, if it would influence their attitudes towards the same person, but who is described differently. So we ended up creating a randomized controlled study where we could actually look at this empirically, right? Because there's been lots of papers. Bill White's written about this. I had written about this before, saying we should get rid of this term, but there was no science on it. So we created a vignette of a person in a drug court situation who was required to maintain abstinence as part of the drug court program. And they had relapsed and they were up before the judge. Okay, so that was the scenario. And in half the vignettes, the person was described as a substance abuser. In the other half, the person was described as having a substance use disorder. And they were randomly assigned to 560 doctoral level mental health and addiction clinicians. So half got the one with describing exactly the same person, same scenario as a substance abuser. The other half got the one describing him as having a substance use disorder. And then they were asked questions about, is this person to blame? Should they get treatment? Should they be punished? Would you have this person marry into your family, et cetera? Normal kinds of questions to do with stigma. What we found was that even in this highly trained doctoral level mental health and addiction clinician audience in this particular convention that we did it in, those who were exposed to the substance abuser label were much more likely to think that person was in need of punishment and more to blame. So exactly the same scenario. The only difference was whether that person was described as having a substance use disorder or being a substance abuser. So what that tells me is that even when we are not aware of it, certain terms can induce implicit cognitive biases. And we have to be careful, therefore, about how we talk about it and write about it. So I think now there's evidence that moves it beyond kind of political correctness. People would argue, well, you know, it's just political correctness. You're just being Mr. Nice Guy, and it doesn't really matter what we call it. But now there is evidence to suggest it does matter, and especially with very highly stigmatized conditions. And this may be the most stigmatized condition in society. There was a study that was done actually by the World Health Organization across 18 different of the most stigmatized conditions. This included being a criminal, being HIV positive, and being a drug addict or being an alcohol addict, illicit drugs or addicted to alcohol. And they looked at this survey across 14 different countries, and the top most stigmatized conditions across all these countries, drug addiction. Number 4, alcohol addiction, out of 18 of the most stigmatized conditions. So these are very stigmatized conditions. We have to do a lot, work hard, and of course, putting a face and voice on recovery is a way to dispel that. Education is another way to diminish stigma, and also changing the language that we use. I was in Budapest a couple of weeks ago presenting to the International Society of Addiction Journal Editors. And the goal of that mission that I went on there was to try and get them to adopt a consensus where we can require people who are publishing addiction science to drop the term abuse and abuser from the lexicon. And instead, just use, a substitute for substance abuse is substance use. You don't lose anything by describing it as substance use or substance use treatment or substance use disorder treatment. So that's a simple thing that we can do to drop that term, and not describe people as substance abusers. Now, for a long time in the mental health field, they've been ahead of us in terms of using person-first language, so a person suffering from or with a certain illness, and I think we can do the same. We can also look to our cousins in the eating relating field. When you look at people with eating-related problems, they are always described as having an eating disorder, never as food abusers. And I think, for some reason, again, part of the rhetoric of the language of the war on drugs has been associated with perpetuating an idea of willful misconduct, with the idea that if we do that, we will prevent use. It has not worked in the way that it was hoped, in that it would reduce use and prevent people from starting use. Unfortunately, that has not worked. Now we need to broaden our scope and adopt a broader public health and recovery paradigm, I think, which is being adopted.
Fantastic. Yeah. And staying with this topic of stigma a little bit, I know that much of the research over the years until recently has been very focused on the problem as opposed to the solution and recovery-oriented aspects of research. And you've done extensive research on 12-step recovery and various forms of recovery, but the media keeps pushing back with their sort of highlighting and illuminating the negative views, both by showing when all the famous people are falling down on their face or not surviving their recovery and going back into rehab and really focusing from that perspective. But there's also written perspective, like authors like Dr. Dodds, who wrote a book which claims that AA is, and this is a quote, almost completely ineffective and even harmful in treating substance use disorders. And the article in The Atlantic more recently that quotes, that can be quoted as calling Alcoholics Anonymous irrational. So I'm curious, you know, you've written some rebuttals, and I'm sure that you're called upon to rebut some of these perspectives. How would you explain that to us, and so that we can start to be on the other side of that argument as well?
Yeah, I've been focused more on, I guess it wasn't purposefully actually focusing on recovery research, but that's kind of where I've naturally gone to, because I've always thought that, wait a minute, you know, we're good at stabilizing, detoxifying and stabilizing people, but we're not very good. We've known this for a long time, that people relapse, you know, and they go back to, they regress into reinstatement of the substance use disorder without ongoing support. And one of the most ubiquitous and cost-effective, it turns out, supports is mutual help. You know, 1.2 million people in AA alone in the United States. That's a lot of resource. Within a 45-minute drive of my office in Boston, there are 1,800 AA meetings a week. There are 600 NA meetings. That's a lot of recovery resource, indigenously embedded in the communities in which people live. It's a natural outgrowth of the need that people saw who had serious addiction problems, that they needed this kind of ongoing support. I was always puzzled why we weren't doing more research in that area, just because it seemed to be working for a lot of people. So I thought, why aren't we using it? Why aren't we doing more research on it? You know, the stuff, the thing to remember, it's hard not to, and I'm susceptible to it too, is the stuff we read in the press, we think it's true, right? I mean, I'm sucked into it too. Not necessarily that, because I know that's not true, the stuff that Laurie's talking about. So that is, it's misguided, it's wrong, it's really unfair. And I think actually it is dangerous also, because you gotta remember, you know, these people, they're not scientists. They're not, they don't understand the literature. They're not reviewing the literature comprehensively. They're picking things that seem to fit. You know, I hate it too when the facts get in the way of a good story. You know, I hate that, but it's true. You know, sometimes the facts get in the way of a good story, and you have to, when we're talking about a public health issue, which is killing 150,000 people every year in terms of alcohol and illicit drug use in the United States alone. Alcohol kills 3.3 million worldwide every year, another 350,000 from illicit drug use worldwide. So we are talking about a major global health problem. And we have to look very seriously at the science in terms of what actually works. So it turns out that in contrary to what was pointed out in those editorials in the popular media, that we've learned a lot. Back in 1990, the Institute of Medicine actually called for more research on AA. And the reason why they did that is because they saw AA being very influential, but there wasn't much rigorous research. Prior to 1990, in fact, the research on AA was viewed as pretty methodologically poor. Now what that did, the Institute of Medicine actually, that called for more research by this very highfalutin body, prestigious body, the Institute of Medicine, it really legitimized serious scientific investigation into AA and the mechanisms through which AA works. So that also meant that the National Institutes of Health appropriated funding, and the Department of Veterans Affairs appropriated funding to really look at this seriously. And that's what's happened in the last 25 years. There's been a flurry of very rigorous research that's been conducted by multiple groups around the country, looking at the benefits conferred by participation in AA in particular, but also other mutual help organizations like NA and CA, and also the mechanisms through which they work, and also how participation can help reduce healthcare costs. So this is another very important issue in terms of our healthcare expenditure, of course, which is part of the reason, the rationale for the healthcare reform through ACA, the Accountable Care Act, was to increase the efficiency and impact of our healthcare system, which was having spiraling costs, but we were actually spending twice as much as any other industrialized country for half the benefit. So a fourfold difference between the service delivered here in the United States compared to other industrialized nations. That's inefficient. We need to do something different. So the issue of cost is very important when we're talking about a very high volume, high burden disease like addiction, which is the top public health problem in the country. So there's been a lot of research done by myself and colleagues looking at this particular issue. This is what we found when we reviewed the literature and looked at the most rigorous studies, is that participation in mutual help groups like particularly AA, because that's the thing that's the most prevalent and been studied the most, actually confers a modest benefit, which is on par with professional treatment. We also find that interventions, which are called 12-step facilitation interventions, these are formalized and structured clinical interventions designed to engage individuals in these community resources, AA, that it can be clinically influenced, that clinicians can make a difference by bringing it up, talking about it, prescribing it, recommending it, and monitoring participation. We can increase rates of participation, and we can, those treatments that have been tested against other kinds of treatments like cognitive behavioral therapy, on average, produce about a 10 to 20% increased benefit in terms of outcomes. One of the, I think, very important aspects also of these interventions, these are 12-step specific interventions to engage people with AA, is that it produces higher rates of continuous abstinence and remission. So there was one very famous study called Project Match. Some of you may have heard of it. It was the largest trial ever done of a behavioral treatment in the world. It was done in the 1990s. And they compared 3 different treatments. One was CBT, one was a new treatment called motivational enhancement therapy based on motivational interviewing, and another one that they tested was 12-step facilitation. And they compared these 3 different treatments for alcohol dependence, and they looked up, followed patients up after they received these 12-week treatments for 3 years after the index treatment episode. What they found was that, that patients actually in the first year who had received 12-step facilitation, 60% more patients were in full sustained remission than CBT. So that's a high difference.
CBT is?
Cognitive behavioral therapy, yeah. So, you know, if you're treating a deadly illness and you had the standard treatment, but you had another treatment that could produce remission 60% higher, to me that would be a no-brainer. And yet, you know what's interesting? In that paper that was published, that's not even mentioned in that paper. They didn't even talk about the fact that that particular treatment increased rates of remission by that magnitude. At 3 years, 12-step facilitation produced 50% higher continuous abstinence relative to cognitive behavioral therapy. Now, this is continuous abstinence, so the continuous outcomes were relatively similar when you looked at percent days absent. But when you looked at full sustained remission, you see a benefit, and you see that replicated across numerous different studies. And the other thing that's, as I mentioned, alluded to, is costs. So we also know from studies done in the Department of Veterans Affairs, very good quasi-experimental studies that have looked at healthcare cost offset. They found the same thing, that patients who are treated in VA system hospitals that are 12-step oriented compared to cognitive behavioral therapy oriented produced higher rates of continuous remission at 64% lower healthcare costs. Okay, so you get a double whammy, that twofer we're looking for. We're looking for better outcomes at less cost. And so linking with peer recovery support entities who are focused on recovery seems to support that notion.
And I'm going to jump to a question related to the community-based and recovery community centers, peer-to-peer support. Can you say a little bit more about your research in that area? I know that's something you're working on right now.
Mm-hmm. Yeah, yeah. So, there are a number of different, mutual help is just one recovery support service, if you will. It's a little different in that it's free and less structured and less organized and that it's self-supporting as opposed to a lot of the other recovery support infrastructure tend to be have support, financial support from state and federal sources. But there are a number of other different recovery support structures. Of course, we've heard some of them already. You all know about recovery high schools, and Laurie here has been a prime mover
Shout out
there.
to University High School folks.
Yeah.
Thanks.
Which just totally wonderful entities. And collegiate recovery programs. There's some of the recovery support services which are embedded indigenously in the high-risk areas where people really need support in recovery. There are recovery community centers, which Tom Hill mentioned, and I have a study right now, NIH-funded study, that is looking at the clinical and public health utility of recovery community centers in the United States. So we are doing a regional study where we're looking at all the recovery community centers in New England and New York State. There are about 40 of these. So we're going and interviewing the directors or the staff, rating the sites. We interview a number of people who are using the centers in recovery, and so we're trying to find out who uses the centers, what do they get out of it, and what's the cost and configuration. And so that will be finished in about another probably year or two. Tend to take time to do these studies, but that will be the first study of recovery community centers. So we'll see what happens there. And there are many other recovery support. So there's sober living that was mentioned already this morning. So Oxford houses, other sober living environments, which have shown to be both effective and cost-effective. Oxford houses, Leonard Jason at DePaul University have done studies on Oxford houses where they've actually randomized people to either stay in a residential Oxford house versus regular outpatient treatment, and they found that individuals who are involved, who stay in the residential facilities actually have twice as good outcomes at about half the cost. Overall, they're also more likely to be employed and to be less likely involved with criminal justice. So these are very good studies, very good outcome, very high degree of rigor. What else?
Well, I'm thinking that you've described several different groups as you've spoken along, and I wonder if some of your research speaks specifically to how different groups utilize recovery and mutual support differently, men versus women, younger people versus older people, people with dual diagnosis, AA versus NA. Can you speak to some of those?
Yeah. Well, one of the things that we've done, we've looked a lot at is the mechanisms of behavior change. So this is one of my interests. This is what when I was in graduate school, I was very interested in the mechanisms through which interventions work. This became a main emphasis of the National Institutes of Health recently, with a real focus on mechanisms. How do treatments confer benefit? And so I've received two or three grants from the NIH to look at mechanisms of behavior change in AA, and looking to see how AA confers benefit. And what we have found is that there are multiple ways that actually AA confers benefit. Another way to think about that is people use AA in different ways that addresses the needs that they have at that particular time in their recovery. So we've done some actually very sophisticated analyses to look at that. Luckily, we've had big data sets where we've been able to look at that with large sample sizes to look at, to see how people benefit. And you know, a lot of the benefit is to do with this fellowship aspect, this social context, that AA participation facilitates changes in people's social networks. So it tends to increase recovery individuals, abstainers in the network, drop negative risk, social risks from the network. It also, and that's a major pathway through which AA confers benefit. The other ways that it works is through boosting coping skills, helping to re-motivate people over time and reappraise the risks and benefits of relapse and recovery. It also helps to reduce craving. These are all empirically supported, the things I'm saying now. These have all been shown empirically to be supported. It boosts people's confidence in their ability to cope with high-risk social situations. It increases ability to people to remain abstinent in recovery when they're faced with negative affect. So when they're feeling depressed or bored or angry or frustrated, AA helps people to maintain abstinence even in spite of that. It also boosts people's spirituality, spiritual practices. That's another mechanism. It reduces depression symptoms in people and boosts psychological well-being. So all these have been shown to be the pathways through which AA confers benefit. One of the other very interesting things is that, as I mentioned earlier, is that people benefit in different ways, or like I said, people use AA in different ways. And this is very similar to the actual psychotherapy research, found exactly the same thing. Although in our models of treatment, we have specified factors which we think are the active ingredients which confer the benefit and produce changes in these different mechanisms, like boosting coping skills, for example, in cognitive behavioral therapy. What actually happens is that, yes, we do that work. We teach certain skills and we promote certain ideas and skills and practices. But what really happens in psychotherapy and clinical treatment, and is also the fact in AA, is that people selectively attend to the things that have the most relevance and salience at that particular point in their life. Women, for example, benefit from AA, we found, differently than men. For men, the biggest benefit in terms of reducing relapse risk through AA is by boosting their confidence to cope with high-risk social situations, right? For women, that wasn't a factor at all, right? For women, the biggest way that AA helped women to reduce relapse risk was by boosting their confidence to cope with negative affect. So coping with depression, anxiety, these kinds of negative affect syndromes and symptoms. Very, very different ways that AA seem to be helping different people. We've also looked at it younger and older people. We've looked at it at more severe and less severe dependence, addiction, and found different mechanisms that people are using it and benefiting from AA in different ways. So it matches the psychotherapy literature. And so people use it. There's a broad array of benefits accessible, I think, through groups like AA, with all the recovery kind of resources available. It seems to fit with, more than the original text of Alcoholics Anonymous, the big book. It fits more with the publication Living Sober, which was published in 1975. So more of what we're finding seems to map on to how people, AA members, describe how they're staying sober as portrayed in that book, Living Sober.
So everybody get that book out and blow the dust off of it.
Yeah. So it seems to be, it seems to be a pretty good match with what we're finding empirically regarding that particular, what people are actually saying in that text.
It's a very practical book. It talks about how to eat a sweet to get over cravings and say again? Take a bubble bath. It's got some very, and that's interesting that it maps back to that. That's wonderful.
No,
that's
it's an
AA.
AA publication. It's called Living Sober.
Yeah, it's a yellow book.
You're thinking of Staying Sober. Yeah, that's the Gorski and Miller book. Yeah.
That's right. Would you say more a little bit about young people in recovery and their use of
Yeah.
12-step programs as opposed to clinical support services and,
Yeah.
and what that looks like to you and how we can help? I know relapse, we often say relapse is part of recovery, especially for young people, but we really want to move them towards their recovery as much as possible. So how would you see that?
Yeah, I think we know that there are common precursors to relapse across the board, across different substances, different levels of severity. The same kinds of things seem to precipitate relapse. One of them is interpersonal conflict, one is negative affect, and another one is social cues, social pressures. There are things like stressors as well as drug-induced relapse, which is taking a little bit of a substance, which can then lead to a full-blown reinstatement of the disorder through kindling craving. When we look at young people in particular, the main precursor we have found with adolescents in particular is not interpersonal conflict, not stress, not negative affect, it's social. 95% of the relapses are to do with these social cues and offers to use or in a context where alcohol and other drugs are present. This seems to be the primary precursor to relapse for young people. So we need to kind of create environments where we can reduce the occasion to exposure to those kind of environments, right? This is not rocket science, this is common sense. We need to remove young people, ideally, who have a substance use disorder out of those environments and into safer environments where there's less exposure and offers where drinking and drug use is not the norm. We get them out of that environment. So this is where, these recovery support services like recovery high schools, collegiate recovery programs, peer support, young persons meeting, APGs, alternative peer groups, all of these ideas make a lot of sense in terms of reducing this major precursor to adolescent relapse and return to use.
Fantastic. And one of your studies showed something related to, in the beginning, young people's meetings are critical, and later on, they'll need some
Right. Yeah.
transformation into other
Right. Yeah, so thank you. Yeah. So we have looked at so we've looked at the impact of age composition of attended meetings on engagement and outcome for young people. So the idea, of course, is that you would think there's a lot of barriers. If you can imagine, the average AA member is 48, the average NA member is 43. If you're a 17-year-old going into a meeting, that can be pretty hard to identify with. There may be addiction-specific barriers. There could be life context barriers in identification. We've looked at this to see whether going to young persons' meetings actually increases engagement. Do they go more? Do they get more involved if there's other young people there? And do they do better? And the answer to that in two different studies, two different samples, two different studies at different times, is that yes. Kind of what you would expect is that the more young people present at these meetings, the more likely the young people who are recommended to go actually will go and then go back if there's more young people. They actually have better outcomes as well. But this only seems to be the case early on. What we've done in the later study where we replicated it, we looked up through 1 year and we found that young people who are still attending predominantly young persons meetings at 1 year actually were doing much worse. So while it can be very important for engagement and getting people in the door and getting them to stick, it might be a good idea to recommend branching out and finding older people who have perhaps more time in recovery, more stable recovery, and more life experience. That's what we're finding.
It's a great finding, and we haven't yet studied it, but we have a nice nuance to the Recovery High School here in Austin, which the Center for Students in Recovery are being trained through the center, the Communities for Recovery, through the YAY program as recovery coaches, and coming back and becoming formal mentors to the high school students. So we're hoping that that will build on some of your findings. So You mentioned spirituality. We know that the biopsychosocial spiritual model is something we talk quite readily about, but that the spiritual piece in that, in terms of research, has only been around a little bit more than a decade. Can you say a little bit about the research on spirituality?
Well, we've known, ostensibly, of course, 12-step organizations have a spiritual basis and overt emphasis on spirituality. And this has been looked at extensively in terms of being a protective factor against onset of substance use and substance use disorders, as well as looking at it in terms of being a protective factor in reducing relapse risk. And there are generally pretty robust the more that religion plays a protective role in terms of onset of use. Less clear on the recovery side, but we have found that, for example, that spirituality is a mechanism of behavior change for participation in AA, for example. And even when we look at 6 different mediators, 6 different pathways through which AA confers benefit, spirituality is still a mediator. Just that spiritual practice alone is still an independent mediator, particularly for people who are more severely affected. I think that just thinking it through, if you believe in divine intervention, kind of there's your answer for spirituality. But if you think it through, what could be some of the psychological mechanisms through which spirituality may actually result in a lower incidence of relapse? How does it do that? How does prayer or meditation actually translate into less use, right? Less relapse. I think the mechanism theoretically is to do with buffering stress-induced relapse. Now, when you think about spirituality, the framework for spirituality, what it does, it helps people to reframe stress. It provides a framework where they can reinterpret stresses in their environment. So, for example, from a 12-step perspective, what is it? No pain, no gain. That pain is the touchstone to all spiritual progress. That instead of pain just being a nuisance, it's actually a stimulus for growth, right? The reframe is a positive one. When you're going through pain, it's not just pain for pain's sake. It's a growing pain. You're going to grow through. So it's that reinterpretation that the spiritual framework can provide, which I think could be an asset that can promote and de-stress people. The other thing is self-forgiveness, is that spirituality often provides a framework for self-forgiveness, which is kind of ironic. In some ways, the disease model is supposed to do that too. You have a disease that is not your fault. It's supposed to reduce the guilt and shame and remorse that accompanies so often addiction. But I think spirituality can do that too, and spirituality can provide that framework for self-forgiveness, which can alleviate that burden of remorse and guilt and shame, which can perpetuate relapse. The other ways I think the spirituality can help is using portable tools like prayer. Now, if you look at the Serenity Prayer, one of my colleagues, Dennis Donovan, he always says, he always thought of the Serenity Prayer as just a cognitive, little tool that you can use because it talks about acceptance and it talks about change and having courage and wisdom and all these things, which when you say that to yourself, there's a part of your brain which hears that. So in other words, that self-talk can mobilize recovery-oriented behaviors. So it's portable, you can memorize it, you can say it, and that can mobilize action and connect people with recovery-oriented action. So I think there's those ways that spirituality can actually translate into a lower incidence of relapse.
And yet still when many people come to program, they say that spirituality piece, the 12-step, all of that is not for me. Some of your work and your book, Broadening the Base of Addiction Mutual Support Groups, Bringing Theory and Science to Contemporary Trend, really points out that there are multiple pathways to recovery and that those that have resistance to or bad experiences with some spiritual aspects of their life, that there are other mechanisms. Can you speak to that?
Sure, yeah. Yeah, I wrote that paper and did that book with Bill White and Jeffrey Roth because we wanted to make sure that there's not a monopoly on recovery in terms of 12 steps. right? Because there are many pathways to recovery. The majority of people actually with substance use disorder recover without formal intervention, okay? Those cases tend to be less severe, less complex, and have more recovery capital at their disposal. The kind of folks that we see in specialty care are people who have much more severe, complex disorders with less recovery capital available. And that combination of factors means that people need ongoing support. For some people, 12-step is too spiritual. For other people, it's not spiritual enough. So there are religious, secular, and spiritual mutual help organizations which have emerged over the last 40, 50 years, including LifeBring and Secular Organization for Sobriety, Smart Recovery, emanating from Rational Recovery, multiple Women for Sobriety. There are a number of different mutual help organizations, as well as other pathways. Medication-assisted treatment, for example, can be a pathway that some people, that's all they need to kind of get them on track and to be able to facilitate changes in their life if they don't have a nagging craving, for example, that can come from post-acute opioid withdrawal. So there are a number of different pathways that people can follow, and that's why we wanted to do that book, to emphasize and put those other mutual aid organizations and other pathways on the landscape. Now, I think in terms of the mechanisms, I think probably there are very similar mechanisms when you think about how mutual aid groups in particular, mutual help groups are organized, is that they are generally organized in group formats and have a social orientation. So when you look at things like group therapy theory by Irvin Yalom, you have all these curative group therapy factors like universality, cohesion, catharsis, altruism, skills building. There are all these things operating in groups, in therapy groups, but in also mutual help groups. So we've got these curative therapeutic factors operating in AA, in NA, in smart recovery, and all of these other factors where people are observing and learning from one another, getting that cohesion and support. And, importantly, what we want to celebrate is a life saved in recovery and a family whose heart is not broken. And if we can find other pathways, that should be celebrated and endorsed and supported.
Fantastic.
Yeah.
Thank you. Well, I'm going to ask a final question, and then we're going to open it up for questions from our group. But as the name of the conference implies, Recovery Capital is our hopes foundation. Bill White defines it, as Jason said this morning. Recovery capital is the breadth and depth of internal and external resources that can be drawn upon to initiate and sustain recovery from substance use disorders. And he adds, and this is my favorite part, recovery capital has a contagious quality. It is time we all become carriers. What would you like to see us doing in the present, maybe 5 years from now, 10, 20 years from now? Where would you like us to be going in terms of enhancing recovery capital in our community and beyond?
Well, that idea of contagion, there are negative and positives to that, right? And I think, the recovery movement, mutual help organizations, all of these things promote this sense of transmission through observational learning, through instillation of hope, that change is possible, that recovery is real, that recovery looks good, right? Recovery is something good about recovery. And that's what's been happening with people like you, Laurie, doing what you do, and everybody here is so inspiring. What's going to happen next week on the Mall in Washington, D.C., again, so unique and historical. It's amazing. It truly is amazing. One of the lines, in terms of this contagion and compassion and acceptance is, I love the line, I steal a line from Fast Car by Tracy Chapman, you know that song? In that song, she says, your arm felt nice wrapped around my shoulder, and I felt like I belonged, and I felt like I could be someone. And I think that, the recovery movement and what goes on in places like this here today is that there is a real or a metaphorical arm around the shoulder that makes people feel like they belong and makes people feel that they can be someone. And that is very, very powerful, that human transmission of connection that can start to build recovery capital, because I think really the beginning of recovery capital is the opening of the door to be all-inclusive and welcoming to people who are suffering. So you can say, you know what, welcome, you belong here, and you're going to be somebody. You can be somebody, the person you're meant to be. And recovery capital, the kinds of things that we've been talking about, and building those resources, allowing people access to those resources, can help them put down the burden of addiction and pick up the tools that they need in recovery. And that's what you're all doing. That's what I see everybody here doing. And can't help but be inspired by that.
Let's give John Kelly a hand.
Thank you. I will bring my client papers. That's my inspiration. No, I read all Bill White's stuff. I mean, Bill doesn't do a lot of empirical research, but I'll tell you what, his framing and architecture has been so critical for people like me and everybody who feels that way. We look for Bill as kind of the architect, and I've learned a lot from Bill. I've had the privilege, to work with him, so I will work with him. But so Bill, definitely from the conceptual standpoint, but there are others. I look across the treatment and recovery field. I look at everything from the neurobiology and genetics up through treatment and the recovery support services. There are many groups around the country. In New Mexico, there's Scott Tunnigan, who's done a lot of research on AA. There is, and recovery support. There's Keith Humphreys at Stanford, and that whole group, which I had the privilege of working with for a few years. Rudolph Moose and John Finney have done some fabulous work in terms of how to study mechanisms of behavior change, which has been very important. Where else? Barbara McCready, who now is at New Mexico, she's done a lot of work in understanding treatment and recovery. Bill Miller as well at the University of New Mexico, who is the kind of originator of motivational interviewing. Alan Marlatt, who was a cognitive behavioral oriented person, he's been a big influence on the field in terms of understanding both treatment and recovery and harm reduction. He's not usually associated with the recovery movement per se, or recovery research, but really he's really done a world-changing amount of good in what he's done. So there are those kind of classic-oriented texts like relapse prevention and so who else? Yeah, I think that's kind of the people who come to mind.
We've got a question here.
So you talked a lot about 12-step recovery and complete abstinence models, and I noticed you just mentioned harm reduction. And I was wondering what you had to say about harm reduction, especially in young people.
Yeah, I mean, harm reduction, any steps in the right direction are good steps. So, I do this clinically. I'm a clinician too. If people aren't willing to go for abstinence, I lay out the rationale for abstinence and increasing the odds of remission and reducing the risk of relapse. But if people aren't willing or ready to go for that, you can't push people before they're ready to go. So I think it's very important to try and work with somebody. Now, my goal always as a clinician is to try and keep people involved in treatment. And so I recommend certain things. I might say, here's the rationale. But I say, you know what, this is what I recommend. If you're not willing to do that yet, I still want to work with you. What are you willing to do? What would you be willing to do to make some progress? What's working for you, what's not working for you, and how can I help you? So harm reduction is, I think it's a real, when your feet are on the ground and you're really in the trenches doing it, you can't help but really work with harm reduction. Because if you don't, you can lose that person very quickly and they could go out and die. So you can increase the odds of recovery if you can keep people engaged in treatment. So whatever it takes to keep people involved, engaged. that's not enabling. That's not enabling their addiction. You're trying to enable their recovery. But if you don't see them, you can't influence them.
Thank you. Obviously, AA has a sponsor-sponsee relationship, and as opposed to a doctor-patient or a therapist-patient relationship. Have you studied, or is there empirical evidence on the efficacy of identification in treatment? Identifying with the person through whom you are getting this help in terms of the efficacy of treatment?
So in terms of, do you mean like being a therapist in recovery or a counselor in recovery? Is that what you're alluding to? Yeah. I think that there's been a limited amount of research on that. That I think they found in those initial studies that it didn't seem to make much difference in clinically, whether the person was in recovery or not. I don't know in those studies whether that person disclosed that they were in recovery or not either. So maybe with self-disclosure and saying, you know, I'm the person in long-term recovery and I'm your counselor too, that might help, build that engagement much more quickly. Not that, yeah, there's not a lot of rigorous studies on that. But yeah, I mean, my impression would be the same as your experience.
We've got a question here, and then.
Thanks, Doc. My name's Jason Martin. I'm a person in recovery, which means to me I haven't had a drink since July 12th of 2014. Great, thanks. What the gentleman was talking about over here, I recently went through a peer coaching class, and one of the things is being able to identify with that person and guiding them along the way or helping them get the resources that they need, and realizing that one shop is not always going to be the best. I've been involved in AA since 1996. That's the least amount of things that I do now. Mostly I do refuge recovery, which is a Buddhist-based recovery. So I guess, where do you see the peer coaching thing coming into the recovery world now?
Yeah, so recovery coaching, peer coaching is taking off all over the country. There are lots and lots of people adopting this peer coaching model. In fact, there's not a lot of data yet, but there's a lot of practice innovations going on in formal healthcare settings as well as recovery support. For example, where I work is Massachusetts General Hospital, right? It's a general hospital in Boston, and we have, you know what the top priority of the hospital is right now for the next 5 years? Top priority of this general hospital, substance use disorder, right? Interesting, first time ever. Now, you know what stimulated that focus and strategic planning and making that the top priority? No. No, it wasn't my research, it was just me being there. No, no, but the reason why was because of accountable care organizations. What that's done is that it has made healthcare systems like Massachusetts General Hospital much more focused on, wait a minute, okay, now we've got a certain amount of money to look after a certain amount of people. We have to be much smarter about how we deliver healthcare. And what they did, well, they said, well, who's actually using the most services, and what can we do to meet their needs better in a more cost-effective way? So and what did they find? Who are they using the most? People with alcohol and other drug problems, right? Because they had high complex comorbidities. They were coming into the hospital again repeatedly into very expensive clinical services. So what did we do? We hired actually 10 recovery coaches, right? Now we've got people who are in long-term recovery themselves. They're embedded in the communities in which our patients come from and to which they're going back. They provide the linkage and support to get them to their appointments, to, warm handoffs, be a friend, a confidant as well as instrumental in getting it. So So there's these kinds of things being adopted. Again, we don't know what the overall impact of that is yet, but these things are being adopted, including at places like Harvard Medical School. Yeah.
Yes, you made a very good point about the Christianity side of being able to get over the addiction and being in recovery, as in like Victory Ministries, Victory Outreach Ministries, started by Freddie Garcia, was a known heroin addict. And just like AA started out small, so did he, and now they're nationwide. What can possibly be done to bring that more to light? Because I tend to see by just questions I've asked with some of the people that I've been around recently that there's not a whole lot of information. Not too many people know about Victory Outreach and their ministry, whereas everybody knows when they hear AA, NA, or CA, hey, lights go up, flags go up, and they know what they're talking about. What could possibly be done to encourage more Christian-based situations like that to prove that there is other ways to overcome your addiction and your substance abuse problem?
Get Bill White to write an article on it. Well, half joking, that's, I mean, actually communicating in academic journals gets all the, gets it out there in searchable databases so people will find out about it more. That's one pathway to increasing knowledge about a group like that. And that would be one thing I'd recommend if you or people who are involved in it could write an article and get it published through something like, there's a journal called the Journal of Groups in Addiction and Recovery, JGAR, Journal of Groups in Addiction and Recovery, and the editor is Jeffrey Roth. He's delighted to publish papers that look at that, even if it was a descriptive paper describing the origins, how it's grown, what it is and what it does, etc., the model of it. That will, just get disseminated through at least through all the, the databases online. So that's one pathway. And then when you have a published paper, again, that's something that you can then send out to people so they can understand and know more about it. So that's definitely one way to do it, as well as the other ways that you no doubt are already doing. That can be another powerful way to do it. Networking, yeah. And the other thing, is, ideally, if you can get, once it becomes a certain size, or if you can get a donation to study it, then you can actually get some data, right, with some harder edges and say, what, people who come, yeah, and then that can actually undergird it, and support it, because then you've got some data and you could say, just like it's happened with AA, it's just that AA took off so, don't forget, it took 50 years before we actually studied it, before we studied AA. Yeah, yeah. Thank
Hi.
you.
You mentioned earlier some of the findings you had about women and young people, and I'm just curious if any of your research has looked at specific cultural groups or racial groups, and any findings you can share on those particular populations.
Yeah, there's been some research, but not very much, that's looked at different ethnic minorities, racial groups. There's been some research that, again, in terms of engagement, the more similar people perceive they are. I think especially with minorities, it seems that, it has been done this work in New Mexico and in California, that blacks tend to go to groups where there's more blacks, that Hispanics tend to go more to groups where there's more Hispanics, and that increases engagement. I haven't seen it where it actually influences outcomes differently, but you would think it would, because it does increase engagement. Unfortunately, most of the samples we get are mostly white, so we haven't been able to or done a good job purposefully sampling larger proportions of minorities to look at that in more detail.
I think there are some researchers out of USC that are doing, looking at recovery and LGBTQ communities, so there's some attention to the culture that there needs to be made.
Yeah, for sure, yeah.
Hi, Dr. Kelly. I've worked for residential treatment centers that use the 12 steps. Some of them would take the clients to the 3rd step, some to the 4th step, and some they would work all the steps. Are you aware of any research that shows which of those have the best outcomes? Or what is your opinion on that?
I don't really know. I don't really know what to say about that, really, in terms of what would be optimal in terms of step work completion. What we do know is that the best thing probably we can do is to increase the chances that somebody will actually go to those meetings when they're discharged, as opposed to working through steps during treatment. You know, it may work, it may be some benefit from doing some step work in treatment, but the majority of the effect seems to be just if you can get people to try it out and go to meetings and develop some preliminary relationships that increases the chances that people will stick and not drop out, they're much more likely. Then they can do their step work in that setting. And some of my colleagues, like Leanne Cascudas in California, has focused on that. That's her thing is really saying, you know, let AA do the steps, because that's what AA does. It helps people with sponsors to work through the steps. Our job is to get them there, is to kind of remove the barriers that and other kinds of preconceived notions that people have, which may act as barriers to participation, to get them to go and try it out. And if we can get them to understand what a sponsor is, what meetings are like, what the social etiquette is in meetings, etc., and all the formats of different meetings, then that's where you're going to get the most bang for the buck, I think.
Yes, it's kind of related to the Victory Outreach question, but your last learning objective is discuss what research reveals regarding spirituality, religiosity, and recovery. So I'd like to hear about that.
Well, as I mentioned earlier, in terms of Laurie's question about spirituality, you know, we know that there is that spirituality and religiosity is a protective factor against the onset of use. It is a mediator, a mechanism of behavior change. As I mentioned, in terms of some of the mechanisms through which spirituality may reduce relapse risk, through providing that framework for self-forgiveness, tools like Serenity Prayer, etc., other prayers. We don't know much about other kinds of entities. There is Celebrate Recovery. Celebrate Recovery is another religiously oriented, Christian-oriented group, which has started now in over 1,000 churches around the country. That's taken off. We don't know anything about it in terms of its ability to, from an empirical standpoint, but my guess is if we were to look and fund studies in that area, that we would find, yeah, you know, it benefits people who go and attend and participate, and they're more likely to stay in remission and recovery. And then we can start to look at the mechanisms through which that happens. But there are different pathways. You know, some are religious, some are secular, some are spiritual. And we need to definitely do more research on the other ones other than just 12 steps, because that's where we've been so far. So I don't think, for example, I would argue, and I think AA would say it's a spiritual, not a religious organization, whereas Celebrate Recovery would say, yeah, we are religious. We're explicitly Christian. Well, one has Christ as the as the obvious and everything that Christ taught in terms of Celebrate Recovery, whereas AA would be really, it's up to you. You choose what your higher power is. Yeah.
I think we're almost out of time. Is there somebody with the mic that has one more question, perhaps?
Going back to like the common precursors in youth, as far as relapse goes, you mentioned that social pressures was one of the top ones. From your perspective, what could account for that, like for that result?
You mean in general or particularly for young people?
Particularly for young people.
Yeah. Yeah, so one of the things is we know that there are conditioned cues, right? So alcohol and drugs, just seeing alcohol or other drugs in the environment can elicit craving. It can release dopamine in the brain, which increases motivation to engage through the memory of that association. So out of sight, out of mind. You know, if you're not seeing it, you're not, you know, thinking about it as much. You still may think about it, but when you're exposed to a cue, the odds increase that you will elicit craving, and that craving could increase the risk of relapse. So that's why those social pressures, in other words, it's not just there's no drugs and alcohol present, but let's go use a drug. That can be one type of social pressure, but oftentimes it's exposure to drugs and alcohol in the environment. And those are what we call cue-induced cravings or cue-induced relapse risk, yeah.
I think Robin
I have
has
one
more round.
last question. You know, one of the things that I'm concerned about as I look around at this wonderful growing peer movement is areas where I see it possibly eroding, where people say that they're providing recovery services, but they're forgetting the peer part. And so it's sort of, I think, like a semantics, you know, one of those little shell games, you know, because they want the result that's provided when you're utilizing a peer-based model of supports and services, but they're not hiring peers, so they're calling them recovery coaches. And I'm wondering if that's an issue that's happening nationally, or if there's some awareness of how to address that effectively.
You know, I really don't know the answer to that. I think it's an important point is, you know, people, you know, adopting a practice we don't really know exactly what the components are and constituents are of best practices, as it were, to use a clinical term, for recovery support service implementation. And that's where we need to be. I think, you know, in the next 10 years, we need to find that out. You know, I believe there is tremendous value in all of these things, all these recovery support services. We need that infrastructure. We need to build it, and we need to test it and evaluate it and find out what's the most optimal way of providing these services. And I think that's where we're going to go in the next 10 years. Yeah.
Well, let's give John one more hand.
Thank you. Thanks for having us.
Fantastic.
Thank you.
Dr. Kelly, thank you so much for what you do. We need you out there, and we really appreciate what you do. Everyone, lunch is next. Please complete your surveys. If you weren't able to get a survey, they should be out on the table. Thank you very much.